Um, Thank you to everybody who's joining us remotely and in the conference room today. I am very grateful that Dr. Katherine Bangen, Katie, has joined us today to present about her research and her professional trajectory. I'm going to give you a little bit of information about Dr. Bangen's background. She completed her doctoral training at the San Diego State University and the University of California Joint Doctoral Program in Clinical Psychology. Her research aims to better understand the functional and structural brain changes that occur in normal aging, mild cognitive impairment, and dementia. Her current projects utilize neuropsychological and multimodal neuroimaging tools to elucidate vascular contributions to Alzheimer's disease. Dr. Bangen's research has been funded by the NIH, the VA Clinical Services Research and Development, and the Alzheimer's Association. So we are very pleased to have her here today. She's been a longtime collaborator of the ADRC and was one of our REC scholars. So that is one reason she's an invited speaker for this series. And we look forward to hearing more about her work and her trajectory. And I just wanted to call out the fact that for anyone online, I have included in the chat a teaching evaluation. So at the end of the presentation, if you would like to give some feedback, that would be great and help her with her faculty file. So thank you so much for being here.
Thank you, Christina, for the kind introduction, and thank you for inviting me. Again, I apologize I can't be there in person. I just have back-to-back meetings and things all day today, but I'm really happy to be with you all. Okay, so Christina talked a bit about my background, but I just want to kind of touch on my academic and career journey. And I should say too, I'll give a little bit of background about me, then I'll talk about some of my research, including my REC project. But I want to leave time for questions at the end. So I'm gonna try to keep watching the clock so that I leave a few minutes for some discussion. But please, as I speak throughout, the talk, please feel free to interrupt me and ask any questions. So I earned my BA in psychology from Boston University. That's where I really got my first exposure to research. So I took a physiological psychology course and ended up doing research with a professor from that class and got really, really interested in both research and neuropsychology. So at that point, I was thinking, I think I want to either get my PhD or maybe I want to go to medical school. I wasn't quite sure exactly what route I wanted to take. So I did a post-bac RA position for a couple of years at Rush University Medical Center in Chicago. And I will say that really solidified my interest in aging and dementia. I worked with Skip Stebbins, who some people may know. Also, Maria Carrillo was there at the time, who's now with the Alzheimer's Association. But they did a lot of work in Alzheimer's disease and also in movement disorders, including Parkinson's disease. So that really, helped me kind of solidify my interests and my path. And then, as Christina mentioned, I came here and got my PhD in clinical psychology in the SDSU UCSD Joint Doctoral Program and was mentored by Mark Bondi. And I completed my clinical internship at UCLA as part of my graduate program. And then I came back to UCSD, as so many people I feel like from our program, have done. So I first completed a postdoc in neuroimaging dementia with Greg Brown as my primary mentor. And that was on UCSD T32. And then I actually did a second postdoc, which not everyone does it. I don't know if I'll recommend it or not, but I did a VA postdoc as well. So this one was focused more on traumatic brain injury and cognitive rehabilitation. And I worked with Mark Bondi and others at the VA, including Amy Jack. And then after that second postdoc, I became faculty with a position at UCSD in the psychiatry department, and also a VA position. And that was really after I secured a VA Career Development Award, which was focused on neuroimaging biomarkers, focused on white matter in mild cognitive impairment subtypes. And then shortly after that, I was fortunate to be a rec scholar. And then after my CDA, I got a VA merit and an R01. I also was fortunate to have an ADRC development project grant as well. And then, since that time, I have my R01 and different, foundation grants as well. Okay, so people probably seen this figure many times, in different Alzheimer's talks, but this is really the model, the different temporal trajectories for various Alzheimer's disease biomarkers. So these biomarkers are changing from normal to abnormal. They're on the y-axis as a function of time or disease stage there, which is on the x-axis. So really within this model, the earliest detectable changes are related to the accumulation of amyloid, which is shown on the far left there in yellow. Then we have changes in tau, which are in blue for medial temporal lobe, neocortical tau there in that orangish color, and then neurodegeneration, and then finally clinical symptoms. They are in green. So really this prevailing model of Alzheimer's disease, as we know, is very amyloid centric. But in reality, we know that individuals with mild cognitive impairment and dementia typically have multiple pathologies that are contributing to their cognitive impairment. So I'm going to show these pie charts here. This is actually from the Rush Alzheimer's Disease Center from Julie Schneider and colleagues. But what they showed is in people who were diagnosed, during life with no cognitive impairment, and then later, went to autopsy, really was vascular pathology was most common. So that's this pink wedge there at the top. Then in people who have mild cognitive impairment before death, vascular only. So again, that pink wedge was very common, AD plus vascular, in this kind of light blue wedge there on the left, and then AD plus vascular plus other, this darker blue on the lower right, were the most common. So only about 8% or so had pure Alzheimer's disease on autopsy. And then, interestingly, even people who are diagnosed during life with probable Alzheimer's disease, it's really this AD plus vascular plus other and AD plus vascular. These large blue wedges are the most common. And only about 3% of their sample had pure Alzheimer's disease. So we can see how common these co-occurring pathologies are, and in particular, vascular changes. So in our own work, we've been really interested in the combined effects of Alzheimer's disease and vascular disease. This is a study that we actually did with the ADRC in their data. And so we had a sample where we had, participants who were all diagnosed with probable Alzheimer's disease during life, and then came, to autopsy, and that Alzheimer's disease diagnosis was confirmed. And we had a group that had Alzheimer's disease plus cerebrovascular changes. So that's this first pie there. And then we had kind of a pure Alzheimer's disease group. And we have people who have more severe Alzheimer's pathology, so higher Braak stage in black, and those with lower Braak stage or less severe Alzheimer's pathology there in gray. So we found that both of these groups, so this kind of Alzheimer's with cerebrovascular change group and then this pure AD group, actually had very similar levels of cognitive impairment. But the Alzheimer's with cerebrovascular change group had less severe Alzheimer's pathology. So again, I'm shown there on the left, so lower Braak stage, more people in that gray wedge. So this suggests that vascular pathology, influences clinical expression of AD, even in patients with autopsy-confirmed Alzheimer's disease, and even people with relatively mild cerebrovascular disease, because we did exclude people with large strokes, clinical strokes, or large infarcts too on neuropathology. So again, pretty mild cerebrovascular changes. So this is another study that I was involved in, out of Rush, where we looked at, multiple different forms of neuropathology. So we also looked at TDP-43, hippocampal sclerosis, Lewy bodies, in addition to Alzheimer's and vascular disease. And we had a lot of statisticians on this paper. I won't go into the very fancy modeling they did. There's kind of a picture of the structural equation modeling that they did. But what we found was in the sample that vascular pathology accounted for 32% of the association of age and dementia. And the remaining pathways, so Alzheimer's disease, Lewy bodies, and TDP-43 accounted for about two-thirds. So just a really large impact of vascular disease and also multiple mixed pathologies, all contributing to dementia. So this is a model of neurovascular dysfunction in Alzheimer's disease that we've often used to inform our work. So it's thought that, several different genetic risk factors for Alzheimer's disease, like ApoE4 genotype, vascular risk factors such as high blood pressure, which are shown there at the top, lead to early vascular damage. And then this, downstream leads to problems with amyloid clearance, amyloid accumulation, tau accumulation, and then eventually neurodegeneration and dementia. So yeah, our lab, has been really interested in looking at different vascular biomarkers. So I'll talk a bit about of some of those methods that we've been using in our lab, but things like cerebral blood flow, arterial stiffening, blood-brain barrier breakdown are some of them. Okay, and then here are, again, the current AD biomarker method. So again, it's possible that these vascular biomarkers might be earlier changes or upstream of the Alzheimer's changes. So we're all probably really well aware just how common, vascular risk factors are in adults in the US and, even more so among older adults. So about half of adults in the US have high blood pressure, according to the CDC. And these conditions are even more common, among older adults, also underrepresented groups, including different ethnic and racial groups. So this is data just showing trends over time and prevalence of different conditions. So in A, we have body mass index, mean systolic blood pressure in the middle, and then hemoglobin A1C there on the right. And so we have different groups in these different lines. So we have white individuals in orange, Asian individuals in gray, Hispanics in kind of that very dark blue, and Black African Americans in light blue. So you can just see that these conditions, are more prevalent in racial and ethnic minorities, likely due to, health disparities. And importantly, vascular factors are often undiagnosed. We see this quite a bit. I work in a clinic at the VA, and we often have people who come in and may have glucose levels that are in the prediabetes range but haven't yet been diagnosed. And so this is also data again from the CDC, but it's showing diagnosed diabetes in the far left column, then undiagnosed diabetes in the middle, and then total diabetes there on the right. So according to these estimates, about a quarter of adults with diabetes are undiagnosed. So we know these are big problems, but probably even larger than we realize if we're just looking at rates of diagnosis. And also then relying on self-report and really under-identify these conditions. So within our lab, some of the different variables, we've been focused in our diabetes. We have a few grants looking at diabetes. Also, we've done quite a bit looking at aggregate vascular risk, especially because these different conditions, tend to co-occur. So we often looked at the Framingham stroke risk profile and other kind of aggregate risk measures, arterial stiffness, which I'll talk about a bit because we've done a few studies looking at arterial stiffness within the ADRC data. So we've looked at pulse pressure, which we can get just from standard blood pressure measurements, and it's just systolic blood pressure minus diastolic blood pressure, as well as pulse wave velocity, which is a more direct measure. And people might be familiar, but we have a device called the SphygmoCor that's used at the ADRC and also in our lab studies to again get this more direct measure of arterial stiffening. We've also looked at some, more recently, some CSF markers of blood-brain barrier permeability, which I'll touch on. And we also do a lot of work in imaging, especially MRI. So to look at cerebral blood flow, white matter lesions, myelin water fraction, and also we have some studies looking at arterial compliance within the vessels in the brain. So arterial stiffness increases in aging and also might be an independent risk factor for pathological brain aging. So this stiffness can damage the microvasculature and also lead to reduced blood flow and possible ischemia. So I mentioned pulse pressure. So again, this is kind of a surrogate marker of arterial stiffening. So during the cardiac cycle phases, systole and diastole, the blood vessels, especially arteries, respond dynamically to the pressure changes caused by the heart's pumping cycle. But as we age, we lose that elasticity of our arteries, and the arteries might become too stiff to distend and then to spring back between heartbeats. So this kind of cartoon shows that, if you have an elastic vessel here, during systole, we should be, distending and then kind of springing back. But the stiff vessel isn't going to do those things. So when this stiffness happens, this causes systolic blood pressure can increase here and diastolic blood pressure decrease, and then that can lead to widening or increasing of pulse pressure. So our group has done quite a bit of work relating pulse pressure to different AD biomarkers. And a lot of this work was spearheaded by Dan Nation, who many of you know, who is here at UCSD and is now at USC. But we linked elevated pulse pressure, so kind of increased stiffening to cognitive decline, functional decline, faster progression to dementia, different Alzheimer's biomarkers are just a few examples of some of the studies. I'm going to show a couple of these. So this is work that was spearheaded by Dan within the ADNI sample. But this is looking at time to dementia diagnosis. We have high pulse pressure, so more stiffening in orange, and then lower pulse pressure there in black. So you can see those in the orange line, that those with more arterial stiffening are progressing to dementia more quickly. And this is work that was spearheaded by Alex Wiegand, who was a JDP student with Mark Bondi. So this is also work that was in the ADNI sample, but what Alex did was she looked at tau, PET tau accumulation over time and how it related to baseline pulse pressure. And she looked at different AD vulnerable regions, so entorhinal cortex, inferior temporal gyrus, and inferior parietal lobe. And across all these different regions, higher pulse pressure did predict increased tau PET accumulation over the 1 year follow-up. And this was adjusting for different risk factors, including age, sex, cognitive diagnosis. So these were all people who did not have dementia. So adjusting for MCI versus normal cognition, APOE4 genotype, and baseline tau PET signal. So I mentioned pulse wave velocity. So this is something we've been measuring in our studies, and also the ADRC has been collecting as well with a special sphygmocore device. But this is a more direct measure of arterial stiffening. So how this works is carotid pulse is measured using a tonometer, and then femoral pulse is measured using a thigh cuff. And then the pulse transit time, so that's the time interval between the onset of the carotid and femoral pulse wave upstrokes. And then the pulse wave travel distance between the carotid and femoral pulse wave recording points is measured just over the body with a tape measure, so not very high tech. But then the carotid femoral pulse wave velocity is calculated as the distance divided by pulse transit time, so meters per second. So with higher pulse wave velocity indicating stiffer aorta. And we've done a few different projects with the ADRC data and as part of my rec work as well. So again, our past work focused more on pulse pressure, and so we started working on these pulse wave velocity projects to try to get a more, direct measure. Also, there weren't very many studies that looked at how pulse wave velocity might interact with Alzheimer's disease risk factors. So we were really interested in looking at that kind of synergistic effect. So this is a study that we published now a few years ago using the ADRC data. But within this sample, you can see that most of our participants were cognitively normal. So we had almost 200 participants and just 26 with MCI. But here you can just see the basic kind of demographics and cognitive performance. So we looked at main effects. So this is looking at pulse wave velocity and cognition. So Z-scores, looking at memory, executive functioning, language, visual spatial abilities, and attention. Again, most of our participants were normal, and those are all the green dots that you see. And then our amnestic MCI are in red, and then non-amnestic MCI in blue. But really where we saw an effect was executive functioning. So poor executive functioning in those with more stiffening. So we know that executive functioning has, often been shown to decline in normal aging. Kind of normal cognitive aging is conceptualized as selective vulnerability in frontal subcortical executive processes. So we think that arterial stiffening, may contribute to this age-related decline. Although I should say we saw this effect even when we did adjust for age. So then when we looked at interactions with Alzheimer's disease, risk factors and biomarkers, and in B, this is looking at ApoE4 carriers versus non-carriers. So E4 carriers are in red and non-E4 carriers in blue. And then below that's looking at AD biomarker positivity. So in red are those who were biomarker positive and blue biomarker negative. And again, looking across the same cognitive domains. When we look at the interaction, we saw effects for memory. So really in those people who are either biomarker positive or E4 carriers, we saw this, effect where higher pulse wave velocity is associated with poorer cognition. And then we more recently extended this in the ADRC sample to look at longitudinal cognitive decline. Because what I showed before were that was a cross-sectional study. And now we have enough follow-up that we were able to look across 3 years and look at change in cognition. And this is work that's spearheaded by Lauren Edwards, who's a current JDP student. And this is actually currently in revision, this paper. But this is looking at, executive functioning and then language performance over time. We have the biomarker negative people in the dots and biomarker positive in the solid lines. And then those with high pulse wave velocity are shown in red. So you can really see that lower line. It's those that are both biomarker positive and have higher pulse wave velocity are declining faster. So as far as we know, this is the first study to look at these interactive effects of pulse wave velocity and AD biomarkers on cognitive decline, across different domains. And so our results suggest there is a synergistic relationship between AD and vascular pathology in influencing cognition. And importantly, arterial stiffness can be reduced through behavioral strategies like increased physical activity and also through different medications. So we think that pulse wave velocity, may be a useful marker to assess risk of decline and ultimately, could be a useful target of interventions to delay or prevent decline. So I'm going to talk a little bit about blood-brain barrier permeability. So people are probably familiar with the blood-brain barrier, but it's a selective permeability barrier that protects the brain from pathogens, helps clear things from the brain, and also maintain CNS homeostasis so that cells can function properly. Blood-brain barrier disruption has been shown to be associated with impaired clearance and accumulation of amyloid. And animal studies suggest that dysfunction in the blood-brain barrier occurs early in Alzheimer's disease, even possibly before the onset of amyloid deposition. So there are different ways to assess blood-brain barrier permeability. So people do this with imaging like DCE MRI, but we have data, with the ADRC where we had use a CSF marker, soluble platelet-derived growth factor receptor beta that we use in this particular study. That's a very recent study that was also spearheaded by Lauren, but in collaboration with Dennis Smirnov, who was used to be at the ADRC, and Doug Lasko and David Salmon and others. But this paper is currently under review, but we did a sample of 83 older adults, again, mainly cognitively normal, but a few with MCI. But you can see here just the demographics. Mean age was almost 73 years old and kind of balanced in terms of sex or gender. And a healthy sample overall, in terms of vascular risk factors, kind of low rates of things like diabetes, high, and smoking. So our models were performed with continuous platelet-derived growth factor receptor beta, but here just showing for visualization that we broke up the sample into high and low biomarker, with high levels being bad. So here we're looking at language. We have those who are E4 positive are in the solid lines, and those with high levels of the CSF marker suggestive of blood-brain barrier dysfunction. It's really a marker of parasite injury, are in the red. So you can see that red solid line. So again, those people who have this marker that suggests some blood-brain barrier disruption, are also E4 carriers, are declining faster. And this is in language I'm showing here. And then when we looked at AD biomarker status. So here we can see those who are biomarker positive in the solid lines. And again, that red line where you can see people are declining faster. That solid red line, those are people who have blood-brain barrier dysfunction, also are AD biomarker positive. So really across these various cognitive domains, we saw that higher levels of this marker was associated with faster decline in people who are biomarker positive. I'll touch briefly on white matter hyperintensities because the markers that I showed before are not really specific to the brain. So we're obviously very interested in vascular changes in the brain and have done a lot of work with white matter hyperintensities on MRI in particular, which is thought to be a marker of small vessel cerebrovascular disease. So this is work from Adam Brickman's group at Columbia and the Diane study that people are likely familiar with. So they looked at people who have autosomal dominant Alzheimer's disease. And what they found is these individuals, they had increased white matter hyperintensity. So really were accumulating white matter hyperintensities many years before their expected symptom onset. And so this is showing mutation carriers in red and non-carriers in blue, and white matter hyperintensity volume as a function of estimated year of symptom onset. So how they calculated that was the participant's age minus their parents' age of onset. So really in this paper, through a lot of Adam's work, they've just argued that how important white matter hyperintensities may be in Alzheimer's disease. And so again, we know that it contributes to clinical expression and also, could possibly be a useful therapeutic target. So in our own work, we've done, quite a bit of work looking at white matter hyperintensities and looking at different regional patterns in different risk groups. This is one study that we published a few years ago now, but this is looking at white matter hyperintensity volume in different lobes of the brain. So in the top, we have frontal and temporal, and then parietal and occipital there in the bottom. We have cognitively unimpaired people in gray, amnestic MCI in green, and then non-amnestic MCI there in blue. So we found that the amnestic MCI showed higher temporal and occipital white matter hyperintensities. So this is kind of in line with Adam's work, where they've shown a lot of changes, especially in posterior regions. And then non-amnestic MCI showed more widespread white matter hyperintensity accumulation, affecting all the different lobes. And this was a little bit more of a mixed group too, with different types of cognitive impairment. But really kind of highlighting the importance of regional measures of white matter hyperintensity, because a lot of studies do focus on global, white matter hyperintensities or total volume across all regions, but there might be some important regional differences.
So,
and so, white matter hyperintensities, we are lesions that are already there that may not be reversible. So we've also looked a lot at blood flow and, thinking this might be an earlier change before people have, frank lesions. So I'm just going to present a couple of, recent studies that we've focused on looking at arterial spin labeling CBF. And this was a paper that was also spearheaded by Lauren Edwards, again, a JDP student in my lab. But she looked at the effect of vascular risk, and this was measured or operationalized as pulse pressure on cerebral blood flow, and whether it varied by gene dose of ApoE4 alleles. So this is looking at CBF across different regions. On the top, we have hippocampus, entorhinal cortex, inferior temporal cortex. On the bottom, we have inferior parietal cortex and some frontal regions. And we have people who have no E4 alleles in yellow, one E4 allele in green, and then two E4 alleles in red there. So it was really those who had two E4 alleles and elevated pulse pressure that had reduced blood flow across these various regions. And in most of our studies, they'll say we don't really get to look at ApoE4 gene dose. So this was with an ADNI where we have a larger sample and we're able to do this. This is just looking at the different regions that were significant. So it was hippocampus, entorhinal cortex, and inferior parietal cortex. And we and others have shown that CBF is reduced in MCI and dementia, but we're also really interested in pre-MCI stages. So this was a project spearheaded by Kelsey Thomas, who's done a lot of work in identifying very subtle forms of cognitive change. So looking at objective, subtle cognitive decline. What she found was really interesting. So this is looking at blood flow across different regions. We have the cognitive impaired in blue, objective subtle cognitive decline in green, and then MCI there in purple. And so we found this inverted U pattern of blood flow, across these Alzheimer's disease stages. So the objective cell cognitive decline group had higher blood flow compared to the other two. So this is in line with actually a few studies that have shown this in risk groups, including ApoE4 carriers, that maybe early on, there could be this increase in blood flow. And exactly what it means, I think it's unclear if it's some kind of compensation or inefficiency, dysfunction. But then as people become more impaired, people have more consistently seen, reduction in blood flow, especially by the time people get to the Alzheimer's disease stage. And those studies were cross-sectional studies, but we've also looked longitudinally at how blood flow predicts future decline in cognition and functioning. So this is from ADNI, and we looked at cognition, we looked at memory, executive functioning, and language. We have people who had low blood flow at baseline in green, and those with higher blood flow, they're in orange. But you can see the group in green there that they're having faster cognitive decline. And this was adjusting for lots of different risk factors. So for demographics, for E4 positivity, for CSF p-tau A beta ratio, and neuronal metabolism. So really, we wanted to adjust for all kinds of other risk factors and even metabolism as well, because CVF relates to both vascular as well as metabolic factors. And so we've also found in this study that those with low baseline CVF, so again, the green line there, they had faster entorhinal thinning, that's shown on the left. They also had faster white matter hyperintensity progression or accumulation, that was just shown there on the right. So I think, one of the things that got me really interested in, vascular risk factors and vascular disease in the context of Alzheimer's disease back when I started, grad school, which was now is over 20 years ago, but was that these, risk factors are, potentially modifiable. And now, there are anti-amyloid therapies and, some progress has been made. But especially, back then, there really weren't a lot of, great treatments for Alzheimer's disease itself. And people have probably seen this Lancet Commission that came out last year, but they identified all different types of risk factors, leading to dementia. And so modifiable risk factors, so things in early life, midlife, and then late life. But they say that modifying, 14 of these risk factors could delay or prevent or delay nearly half of dementia cases. And about half of these risk factors are vascular risk factors, so things like cholesterol, physical inactivity, diabetes, smoking, high blood pressure, obesity. So again, this is what got me really interested. And I know this is a lot of advice that we're often, giving to our patients as well in trying to optimize brain health. And there have been studies, people probably are, familiar with the Sprint Mind trial, but this was an intensive blood pressure control study. And so the goal was in the intensive treatment group to reduce systolic blood pressure to less than 120. And there was a standard treatment group to lower systolic blood pressure less than 140. And what they showed was MCI was reduced. So incidence of probable dementia and MCI, when they did a composite MCI and probable dementia grouping, was reduced in those with intensive treatment group. So I think this study is really interesting and just provides good evidence that if we do control these vascular risk factors, we may be able to reduce future cognitive decline. So to summarize, cerebrovascular risk factors are common, and I didn't talk too much about our research in midlife, but we've done a lot of work within midlife, particularly within the Framingham heart study and looking at midlife vascular risk predicting outcomes in late life. But that Lancet Commission study, obviously, a lot of those vascular risk factors are in midlife that they're pointing to. So these can increase Alzheimer's disease risk. mixed vascular pathology and Alzheimer's pathology is very common, even in people who don't have dementia, and even in people who are diagnosed, during life as having probable Alzheimer's disease. Cerebrovascular disease increases odds of dementia among individuals with co-occurring Alzheimer's disease pathology. Proposed mechanisms of the effects of these vascular conditions on cognition include damaging the microvasculature, also interfering with amyloid clearance. And differences in risk factors across racial and ethnic groups may be moderated by social determinants of health. And subtle and subclinical cerebrovascular changes, so even things like pretty minor reductions in blood flow, predict future decline in cognition and functioning, future neurodegeneration, and cerebrovascular disease. So again, vascular markers can be useful as biomarkers to detect risk and also as potential treatment targets. Particularly given that lifestyle changes could have a large impact on prevention of clinical dementia. Okay, so kind of future directions, within our lab, we're studying different biomarkers. So again, interested in blood-brain barrier permeability, also looking at cerebral arterial compliance within the brain. So again, those pulse pressure, pulse wave velocity measures are really looking at the periphery, but now we have some specialized arterial spin labeling scans that we can use to look at compliance within the brain. We have some different projects focused on midlife or midlife to late life. And also, the Jack curves that I showed at the very beginning that people have seen many times, suggest that, cognitive changes are detectable, very kind of late in the disease process. But really, if we use more sensitive markers, we may be able to detect those types of changes earlier. So, I discussed some of the subtle cognitive decline work that Kelsey spearheaded. We've also done quite a bit of work recently looking at individual cognitive variability as an early marker, because people might show some very subtle variability before they actually would meet, thresholds for cognitive impairment. And obviously, we need to diversify our clinical research cohorts. So yeah, I want to thank the ADRC and my lab members, also the REC program for funding, some of this work.